Thank you so much, Dr. Salo. Assalamu alaikum wa rahmatullahi wa barakatuh. I'd like first to thank all of the organizers and the radiology department. Special thanks to Dr. Shema Abdusattar for her generous invitation. Thanks also to my dear professors and colleagues in the neuropathology team, headed by our dear Professor Dr. Salo and Dr. Manel. And also I'd like to thank all the audience and the colleagues. So I am going to go to see the case 2 from the pathology perspective. Actually, when we receive a case, a neuropathology case, most of the time we receive it in the laboratory as pieces, because in most of the cases we don't have the tumor removed in total. So the fragments usually don't get enough information for us to describe the tumor. So actually our gross, we always borrow it or learn it from the radiology reports and the radiology films. This is where we see all the extension of the tumors, the shape of the tumor, and as all the important information my dear colleagues from radiology department have mentioned. So this is our eye to the tumor. Then we go to our sections under the microscope. In fact, the pathology slide is a secret world. The radiology films are always available, we can see it, but the problem is always the radiology slide is a secret. You don't know what's happening under the microscope. So maybe today we are exploring with you some of our features under microscope. This is, for example, the tumor that we saw in this case. So the tumor here shows what we call it rosettes, okay? And rosette is arrangement of cells around central structures. The central structure can be a lumen or can be a fibrillary material. These are other areas of the tumor. It becomes hypercellular in other areas. Again, other areas that you can see here, we start to have more vague rosette formation. When we go for assessment of high-grade features, this tumor was having high-grade features focally, like high mitotic activity, necrosis areas with palisading quality, and microvascular proliferations also. So when we come to assess the case from our point of view, we have a differential diagnosis that is based on either the clinical and the radiological findings, and then we combine it with our histological differential diagnosis. So from point of view, as all my colleagues have mentioned, as a pediatric patient, this is a 2-year-old posterior fossa tumor. We have the medullopendymoma, ATRT, some types of astro, CNS tumors with weak or internal tandem duplication. These are the most commonly encountered in this age group, in this location. If I look at from the other side to it, from the side of pathology, I will find the rosettes. So if I find the rosettes, this may be an ependymoma, maybe medullo, maybe ATMR, maybe also neuroblastoma or B-core mutant tumor, or other tumors that are irrelevant to the tumor site. So what actually we do, we combine both together. We combine the location, the age, and we combine the histology so that we can move to our next step of validation of what we see. Now I want to show you this nice slide. And this is again from, this is a paper called Neuropathology for the Neuroradiologist. It's only talking about rosettes and the types of rosettes. So we have different types. We have the Homer Wright rosette. Maybe they look the same for you, but they are really different when we look close. This is the Homer Wright rosette with arrangement of cell around the confined central neuropil area. This is in medullo. Here we have the true ependymal rosettes around central canals. Here we have the perivascular pseudorosettes. It is in the ependymoma and the B-core altered tumors. The ATMR, the multi-layered rosettes, the neurocytic rosettes and neurocytoma and so on. So there are a lot of clues in our rosettes in our slides. So now we move to the next step of validation, which is the immunohistochemistry to predict the nature of the cells. Actually, we have a lot of lists of immunohistochemical markers that we can use to investigate the nature of the tumor. What we do actually is a cocktail, according to what I see. Now, my suspects are, if I go back to the slide of differential diagnosis, my top suspects are ependymoma and medulloblastoma, but I'm leaning more to the ependymoma because of the quality of the rosettes. So now I'll start to pick up from my cocktail, forming my cocktail. I'll pick up a glial marker, I'll pick up ependymal marker, I'll pick up a neuronal marker to exclude medulloblastoma, I'll pick up other markers, for example, if I want to exclude ATRT, and this is how I make my cocktail and design my immunohistochemistry plan. So in this case, it was positive for GFAP S100, confirming the glial nature. Here we have characteristic dot-like, what we call it dot-like. And actually, many of our dear clinicians, they come to ask me when they read, because now they read a lot in the details. So they tell me, what is the dot like? What is the rosette? So we are happy to share what we see also under the microscope. So this is the dot-like EMA staining of the tumor cells. This is synaptophysin negative, excluding medulla. This is retained INI, excluding ATRT, and Lin28 also was negative. Ki proliferation index was high for this case, confirming also what we see, high-grade features under the microscope. So putting all the data together for us, this is a case of ependymoma also, but again, what's next? It's not, because ependymoma, we all know it's an ependymoma. So again, we have now to move to the integrated diagnosis. For us, now, according to the most recent classification, the 2021, we have to layer our ependymoma classification, anatomical, molecular, and WHO grade, as my dear professor, Dr. Iman, mentioned. So this is how we have to report it. So let's finish the WHO grade first. I'm not going to go through this busy slide, but just to tell you that the ependymomas can present in 3 different grades. Subependymoma is grade 1. Myxopapillary ependymoma used to be grade 1, now moved to grade 2 by definition. And the other ependymomas we grade 2 or 3 according to presence of histologic features of high grade. So now this is a high grade case, our case, so this is a grade 3 ependymoma. Also, another thing we have to mention here, we lost the word anaplastic. Now we cannot say anaplastic ependymoma. This is an old term. Now we just mentioned the grade. The same is for astro also. Now we don't say anaplastic astro, anaplastic oligo. This is not now present in the new terminology. We just mention a grade. Sometimes we write formerly anaplastic because we don't want to leave the terms. So this is a grade 3. This is part of our classification. Anatomical compartment and the molecular group, of course, we know now it is a posterior fossa. Again, this is the classification, the refined classification of the ependymoma. I'm not going to go through all of them because we don't have a lot of time. But again, we have different different groups in different compartments. The supratentorial, they have group. Infratentorial, they have a groups. And also spinal, they have groups. And this was all done by the DNA methylation profiling, as my dear Dr. Iman mentioned. So I'm skipping those. I just want to touch on 4 main types, the molecularly defined types. Supratentorial ependymoma. We have the ZFTA fusion positive. This tumor was called the RELA fusion positive before, and now it's ZFTA fusion positive. It is a molecular definition. We have to do the molecular. There are some characteristic features, and there are some immunostains that can help, but by definition, this is a molecular entity. This tumor also can be found in grade 2 or grade 3. It is not a high grade by definition or low grade by definition. The next one, the supratentorial, again, it's a molecular entity. It has to have a YAP fusion protein positive with other with other protein products. This is more common in younger children, and it has better prognosis than the ZFTA fusion positive tumor. So if I have a supratentorial ependymoma and I don't have this molecular classification, what should I do? We can always refer to say it is NOS. It is not otherwise specified. The next thing we have to say, does it matter for the treatment to classify supratentorial ependymoma to ZFTA fusion or YAP1? Till now, in Egypt, it does not matter if this is this one or this one. There are other factors that will help to stratify risk of ependymoma till now, and they don't include this. This is just a prognostic, but it is not helping in the diagnosis till now. The treatment till now. Now for our case, the posterior fossa, we have type A and type B. The main difference between type A and type B is a modification in the methylation profile. The type A has a loss of H3K27ME3 trimethylated histone. It is lost in this tumor. This makes it aggressive. Okay, and the type B retains this gene, so it makes it more of a better prognosis. Type A is more common in the younger children or a young age group. Type B is seen in older patients. So again, here this one can be done by immuno, not only by molecular. The surprise here for the posterior fossa is that actually if I do the molecular, the methylation for the histone, it's only positive in 4% of cases. So here the immuno matters for the posterior fossa tumor. And this is good. This is the posterior fossa beam. Again, I can always say it is NOS if I did not do the test. Finally, I just want to mention that, again, there is a group in the spinal ependymoma that behaves aggressively, and it have shown amplified NMEC gene. I'll skip that. So what about this case? What happened? So anatomical compartment, it is a posterior fossa. Molecular group, this is a posterior fossa. I have to do the immuno. At that time, when the case was done in the Merdesh, the immuno was not available, so it was not done. But we tried for the molecular. It is a very low chance to get it, but it was negative. It does not mean that it is negative, because it's only present in 4%. And now there are, alhamdulillah, some labs started to get this immuno, so now for the coming cases, we can stratify this posterior fossa ependymoma properly. So at that time, we said it is an NOS. We did not do the proper test to classify. It was not available at that time. So the final diagnosis for that case was posterior fossa ependymoma, not otherwise specified, CNS WHO grade 3. The tumor is of high risk. Why? Because of many things. Because at that time it was subtotally resected. It was not a complete resection, and this is very important. Also, it is having this posterior fossa location sometimes increases the risk, and it is a grade 3. So it is high risk, and maybe the management plan will follow according to that. I'll conclude now with this slide. These are 3 photos. You can tell me, are these 3 different tumors or the same tumor? And these are 3 different areas. Can we say anything, even pathology, Yeah, this is exactly what we see. So sometimes it really, they look the same. Sometimes you don't know. And this is just to emphasize that it is not only one test to help to reach anything. It is a combination of tests and tools that we can let us reach a proper diagnosis. Because for your surprise, these are 3 different tumors, 3 different treatments, and 3 different, and even the grades are different. Some in the middle one is an aplastic ependymoma grade 3, and the others are grade 4. So it can make a big difference. So if I rely only on one test, I cannot rely on radiology only, or histology only, or immuno only. It's the combination of the factors that can help me to reach the proper diagnosis. Then, after dealing together, talking together, exchanging our experience together, in the MDT will be given to the oncologist and the neurosurgeon to design the further management plan for the patient. These are my references. And finally, I want to say that the tough times don't last, but the tough teams do. So I'm very proud that we start teams in Ain Shams University in different disciplines. One of the most powerful is the neuropathology team. And now there is a lot of great effort done by the neurosurgery department also to start the frequent MDT meeting, and we meet there. So it is a great chance for all of us to increase our experience and to serve our patients more properly. So again, thank you very much, all of you, and all the best for the conference. Thank you.
شكرا جزيلا يا دكتور ريهام على البرزنتيشن الجميلة ديت، ويسعدني أقدم الكيس رقم 3. هيقدمها الدكتور أحمد دسوقي from Radiology Department.
Thank you so much, dear professors, chairpersons, and colleagues. All right. I think our heads are spinning around now regarding the pediatric brain tumors, but hopefully we will see about the spinning by the end of this session. All right. So our case today starts with a story of a 14-year-old female patient presented to A&E with severe headache and blurry vision. Ophthalmological examination revealed papilledema. So CT scan was done for the patient, and it revealed a mass in the inferior left cerebellar hemisphere, as you can see here. And, well, it's predominantly cystic with a solid component, and there's associated mass effect with partial compression of the inferior fourth ventricle. An MRI was done for the same patient, and again, it revealed a mixed solid and cystic mass. The solid component showed a homogeneously T2 hyperintensity, and the cystic component showed high signal. And as you can see here, there's peripheral enhancement of the cystic component of the mass. Again, in the T2, as you can see, the solid component is iso to hypointense compared to adjacent brain, and the cystic component shows fluid signal. In the T1 contrast enhanced imaging, there's vivid contrast enhancement, and again, cyst-tool enhancement appears. So, yeah. All right. Is there any diffusion restriction in these images? Well, the answer is no. So there's no diffusion restriction, as Professor Shaimat mentioned in her lecture, commenting about the diffusion restriction. So it's very important to look at it while assessing pediatric brain tumors. Right. Okay, so here's the question. What is your diagnosis for this case? The images shows the location, and here's the diffusion, and the possible answers are hemangioblastoma, pilocytic astrocytoma, ependymoma, and medulloblastoma. So there's the QR code, please. You can scan it on the tables or on the screen. Let's see what happens. Right, I'll give you 30 seconds. Right, time is up. And the answer is, can you please show us the poll result? Nice. Right, we got, what, 9 answers? Okay, and the answer is pilocytic astrocytoma. So here's our diagnostic flow chart, as we have seen it a couple of times before in this session. So this is the posterior fossa tumors. We go to the location. If it is in the cerebellar hemisphere, we check the diffusion restriction, and with relative comparison to the gray matter. And if there's no diffusion restriction, we will check if it is cystic and solid, has cystic and solid components. If it is, so it's most probably pilocytic astrocytoma. Again, I'd like to highlight that these flow charts is for guidance, and they are, well, let's say mostly the typical cases, the majority of cases, but of course there are exceptions, and we will explore a case of an exception later on in this session. Right, so pilocytic astrocytoma, and we go to the WHO classification of circumscribed astrocytic tumors. The pilocytic astrocytoma is a type 1 CNS WH grade, which is, well, means that it's a slow-growing, non-malignant, associated with long-term survival, and have a relatively good prognosis tumor. Right, so pilocytic astrocytoma, again, it's the most common primary brain tumor in children. The location is mostly in the cerebellum, and the treatment is surgical resection or adjuvant chemotherapy if unresectable tumor. Right, and what about the imaging features? Well, this is what's interesting for us as radiologists. So it's mostly a cystic solid mass with a large cystic lesion and a brightly enhancing mural nodule. In the T1, the solid component will be iso to hypointense, and the cystic component will show fluid signal intensity. The T1 contrast enhanced imaging, of course, it will show contrast enhancement and the cyst-tool enhancement, which is, again, in the majority of cases. Regarding the T2 signal, the solid component will be hyper intense, and the cystic component will show high signal intensity. And to judge the diffusion restriction, of course, there will be no restricted diffusion relative to the gray matter. Right, so what is our differential diagnosis? Probably we can have some guesses from the previous sessions. First of all, it's medulloblastoma, ependymoma, hemangioblastoma, and abscess. And of course, by the end of this whole session, we will have a good conclusion about how to differentiate between them. So let's go to the other story of the other girl. She's a 15-year-old female patient presented to A&E at Ain Shams University Hospital and with severe headache and ocular pain. The ophthalmologic examination revealed grade 4 papilledema and macular edema, and the patient was referred to radiology for urgent CT at Al Falah unit. And here are the CT images. Right. So, as you can see here, there's crowded foramen magnum. Sorry, markers. So there's an expansile lesion occupying the brain stem, a bit crowded. The medulla appears a bit enlarged, and there's compression on the fourth ventricle, and there's evidence of supra and infratentorial hydrocephalus. Right. So the MRI images, again, there's a partially cystic, partially solid space-occupying lesion seen originating from the posterior aspect of the cervico-medullary junction. And in the T1 contrast-enhanced imaging, there's again contrast enhancement, and the cyst wall again is enhanced. In the T2 imaging, the solid component will be hyper intense, as you can see, and the cystic component will show high signal intensity. And there's resultant fourth and third ventricle. Sorry about that. Let's close the. All right. So there's resultant fourth and third ventricle blockage by the mass. And let's go. So what we see here, and the most interesting note is back to the flow chart. To diagnose pilocytic astrocytoma, we mentioned that the location is cerebellar hemispheres, but here it is not in the cerebellar hemispheres, it's basically in the medulla. So variations happen. And this is the highlight of this case. So it's an atypical case, and we might see it in our practice. So the other locations for the pilocytic astrocytoma might be the brainstem, the optic pathway, which is common in neurofibromatosis type 1, and also the spinal cord, which will be spinal astrocytoma. Right. An important note, if the patient is neurologically unwell, meaning there's acute hydrocephalus, so urgent CSF diversion should be done. And this is what happened to this case. So, as you can see, the imaging modalities used to diagnose this patient is CT. And if the patient is neurologically unstable, we will not go for MRI. We have to stabilize the patient first, do the CSF diversion, and then follow up the assessment and treatment. But you can go to the MRI if the patient is neurologically stable. Right. So the take-home messages. First, as you can see, there's no rule for contrast-enhanced CT in diagnosing pilocytic astrocytoma. We just did a CT and a contrast-enhanced MRI. Second, the urgent CSF diversion is crucial in acute hydrocephalus, and always check the diffusion restriction, which is a central part in the algorithm of diagnosing and differentiating the pediatric brain tumors. And finally, you should make friends in the pathology and pediatric surgery departments, apart from being very nice, but they will help you a lot. Team acknowledgement. Thank you so much, Professor Shaima and colleagues in the radiology and pathology department. And that's my final slide. Thank you so much.
Thank you. Thank you so much, Dr. Ahmed. The next speaker is Dr.